Talks focused on IBS, and I'll now hand over to my two co-chairs, Dr. Mohammed Taufiq and AJ Verma, to introduce the next two speakers.
Thanks, Rena, and welcome to Sheffield. First of all, I'd like to say happy birthday to my co-chair, AJ Verma. Sheffield's the best destination to be spending your birthday. Without much ado, I'd like to introduce our first speaker of the session, Dr. Anupam Rej. Anupam Rej is a senior registrar here in Sheffield. He's one of our own. I'm also delighted to say that he's going to be one of our colleagues. He's been appointed as consultant gastroenterologist here in Sheffield, and he's done extensive research in IBS. Dr. Rej.
So thank you for the kind invite. So today I'm going to talk to you about the role of dietary therapies in IBS. So as you all know, IBS is really common. It has a global prevalence of around 4%. And we know that this is something that we encounter very frequently in our day-to-day clinical practice. So in terms of management options, as we know, we have essentially three arms for management for IBS. So we have pharmacological therapies, which I think Professor Ford's going to touch upon in the next talk. We have psychological therapies, which can sometimes be quite difficult to access. And finally, we have dietary therapies, which will be the focus of the next kind of 15 minutes or so. So why am I talking about a diet? Well, we know that diet is a key trigger for symptoms in patients with IBS. And we know that it can trigger symptoms between 60 to 80% of those patients. And what you'll see from this slide, if you look at the figure, this is a study that was published a couple of years ago that noted that many individuals with IBS have several food triggers. And the more severe the IBS, the more food triggers that you have. And many patients self-impose dietary restrictions as well to manage those symptoms. So in terms of dietary options, we have traditional dietary advice, and here in the UK guidelines, that is considered first-line management. And if that doesn't work, then second-line management is the low FODMAP diet. And I've also mentioned here the gluten-free diet. Now, that isn't part of the national guidelines as it stands, but I'll talk to you about some of the emerging data for that as well. So if we talk a bit about traditional dietary advice, so this is essentially simple lifestyle measures such as eating small, frequent meals, encouraging fluid intake, avoiding caffeine intake, and these are guidelines that are set out by the British Dietetic Association as well as the National Institute for Health and Care Excellence. And I think the thing to say here is that the evidence is mainly from case control studies and clinical experience, and we have a lack of randomized control trials looking at the efficacy of this approach. And also, another important point to say is that, to my knowledge, there haven't been any studies directly comparing traditional dietary advice to a habitual or a sham diet. So if we talk a bit about the low FODMAP diet, I'm sure all of you use that as part of your clinical management for patients with IBS, and it's a multiphasic approach. So you have the restrictive phase, which takes between 4 to 8 weeks. Then that's followed by a reintroduction phase, which can take up to 10 weeks. And after that, patients then go on to a personalization phase. And I think it's important to stress that in the long term, all patients should be on the personalization phase of the low FODMAP diet to prevent potential nutritional inadequacy. And you can see through having multiple phases, it's important that we have dietitians to guide patients through this process. So if we look at the evidence for the low FODMAP diets, I've shown you a figure from a recent systematic review and meta-analysis here. And essentially, to summarize from this, I would say that there are good evidence for short-term benefit of the low FODMAP diet, particularly in the restrictive phase at 4 weeks. I think in terms of long-term outcomes, that's emerging, and we probably still need a bit more data. And some other important points with regards to the studies are that the majority, if not all of these studies, have been dietitian-led studies rather than physician-led. So I think that highlights to you that the evidence for us is based on dietitian-led therapy, which is really important. And also, the other thing of note is that these studies have been done primarily in secondary care and tertiary care. So we're not really sure whether that actually applies to primary care. So if we think a bit about the long-term outcomes of the low FODMAP diet, I'm presenting some of the data that we published here in Sheffield looking at the long-term outcomes from the low FODMAP diet. And what we noticed was that there was a response rate of about 60%, but we also asked patients in the long-term phase of the low FODMAP diet, what products were they requesting? And you can see from this slide that almost half of patients were asking for gluten or wheat-free products. So it appears empirically patients are asking to have a gluten or wheat-free diet as part of the low FODMAP diet, and that might just be a simpler way of doing it. So the question is, why are patients asking for gluten-free products? Well, it's been hypothesized that this could be an easier way to reducing FODMAPs. So if you look at this slide here, in green, these are gluten-free products, and you'll see that a large number of these products have high fructan content and high galacto-oligosaccharide content as well. So actually, by reducing gluten, maybe we're just reducing fructans and reducing FODMAPs, and maybe that's why patients are taking it. But there are multiple pathophysiological mechanisms at play, which I'll discuss a bit later on. So what I would say is that I think that wheat is key in terms of symptom triggers for IBS. We know that it can trigger symptoms in up to about 30% of individuals. And as I say, I think there are multiple potential components of wheat that could trigger symptoms. So I've touched a bit about fructans and FODMAPs. I've spoken to you a bit about gluten, but there are also other components such as wheat germ agglutinins and amylase trypsin inhibitors. And also it's worthwhile noting that some of this could actually be a nocebo response as well, and that's always worthwhile bearing in mind when we're doing dietary studies. So if we look at the evidence for a gluten-free diet in IBS, I'm showing you a systematic review and meta-analysis from a couple of years ago. Now, this only included 2 of the randomized control trials for a gluten-free diet in IBS. And at that time, the authors concluded that there was insufficient evidence to recommend this diet. But what we do know is that since then, there have been more and more studies showing the benefits of a gluten-free diet in IBS. And maybe we need a more recent meta-analysis to look at that. But I think that things are continuing to grow for this. I think another important question is that how do these diets compare head-to-head? And which diet is best? And I think this slide demonstrates that there's a lot of uncertainty with regards to this. So if you look at the top left-hand side of this slide, this was a study that was performed in Sweden, which showed that both traditional dietary advice and the low FODMAP diet led to symptom improvement, but there were no difference between groups. Likewise, there's been a study in the US, which again has shown no difference between both interventions, although there was an improvement in abdominal pain for the low FODMAP diet compared to traditional dietary advice. And relatively more recently, a study in Iran showed that the low FODMAP diet was superior to traditional dietary advice. So you can see here, there's still a bit of uncertainty, and we certainly need more studies to clarify this issue. And actually, more recently, there's been a network meta-analysis led by Professor Ford and his team, and what they concluded was that the low FODMAP diet was superior to a habitual diet for global IBS symptoms, and that wasn't seen with traditional dietary advice. So from that, you might argue, well, maybe we should be using the low FODMAP diet as first-line therapy. But I think what I would say is that we just don't have enough studies looking at traditional dietary advice, and the studies that we have had a small number of participants. So I don't think we can draw those conclusions right now, and I think we just need more data. Talking about more data, I think, again, to my knowledge, we don't have any randomized controlled trials comparing all 3 diets head-to-head. Now, I've just shown you some of the data that we have here from Sheffield that we've yet to publish. And this was a randomized controlled trial looking at all these 3 diets at short-term outcomes. And what you'll see from this slide is that the response rate was similar between all three interventions, varying between 46 to 58% or so. So from this data, you might conclude that actually maybe all these three diets are quite similar. I guess the next question is, what do patients actually want? This is some data from a study that was performed in Italy, where patients had the Mediterranean diet, followed by the gluten-free diet and the low FODMAP diet. And what they did is they asked patients, what do you actually want? And what you'll see from this slide is that the overwhelmingly majority of patients wanted a simpler diet. So they wanted a Mediterranean diet, and only a small number wanted a gluten-free diet in terms of 11%, and even a tiny proportion, 3%, only wanted a low FODMAP diet. So this could, with this data, you could argue that maybe patients want simpler approaches, such as traditional dietary advice. So I've shown you some of the data, and the question is that what should we be doing? So I'm going to give you what my opinion on this is. So as I've said, diet can trigger symptoms in a large proportion of patients with IBS. I've shown you the efficacy of all of these three dietary approaches, and I think there's still uncertainty of which diet is best when comparing them head to head. So I would argue that all these three diets are on the table for patients with IBS, and it should really be led by patient choice in conjunction with a dietitian. I guess the next question is, I keep on saying that these therapies should be led by a dietitian, but can we actually deliver these services? Now, looking at the literature, we know that about 45 to 60 minutes is required to deliver the first part of the low FODMAP diet. But in reality, most trusts can't provide that level of time for our dietitians. And this was a survey that we did across England looking at that. And what you'll see is that only 14% of trusts provided that adequate time for those dietitians to see these patients. So we need to think of more novel ways of delivery. Now, that could be through group sessions. And again, looking at the data across England, we know that about 30% of trusts provide group sessions for patients with IBS. But also, post-COVID, maybe we need to move to online webinars to deliver these services. So, to conclude, I would say that there's a growing evidence base for dietary therapies in IBS. We just don't have many head-to-head studies, and I think we need more to see which diet is best. I think in the meantime, I would say that all these three diets are potentially effective approaches, and they should be led by the patient in conjunction with a dietitian. And I think that the way that we'll be able to deliver these services is to move to online webinars and group sessions, and I think that needs further evaluation. Thanks very much for your time, and I'd be happy to answer any questions.
Thank you, Pom, for an excellent talk. I've got a question for you. So if a patient's tried a traditional diet and they've not succeeded and they felt terrible, does that have any impact on the subsequent initiation, for example, of the low FODMAP diet? Is there any data to that?
So I think that's a really good question. And as it stands, there is no data looking at an individual having traditional dietary advice followed by the low FODMAP diet or gluten-free diet. And I think that's an area that needs to be looked into going forward. But in general, that's the way that the practice is right now, but I think we need more data.
Thank you.
Are there any questions from the audience? There's one question online, I've just picked it up, Pom. Are there any data of impacts of low FODMAP diet on mental health of IBS patients and possibly exacerbating eating disorders?
Yes, so I think the issue of eating disorders is an important one, such as the risk of orthorexia nervosa in patients following any sort of restrictive diets. Looking at some of the data that we have, looking at the low FODMAP diet, it can have an impact on quality of life, much like any other dietary therapies. And actually looking at what patients prefer, they tend to prefer more simpler approaches, such as traditional dietary advice, looking at the literature and data.
Thank you very much.
Thank you.